Okay, welcome everyone, and thanks for joining this Alliance for PH webinar. My name is Rob Platika, and I'm a director at the Partners for Patients Foundation. We've been very happy and proud to support the Alliance as the Secretariat, and would like to thank Pisana Ferrari for helping to organize this webinar. And yeah, today's webinar is digital tools and real world approaches for everyday PAH care. This is number 2 of 4 quarterly webinars that the Alliance is organizing in 2026. We've been organizing them for a few years now, so you can look back on our YouTube channel and see if there's other topics that interest you. Today, we look at practical digital tools, approaches that are already available, already making a difference for people living with PAH, from remote monitoring and home-based tests to staying connected with clinical teams and accessing mental health support online. This will be about 1 hour with questions towards the end. If you want to put a question in the chat anytime, you're welcome to. The recording, the slides, and the transcript will be available later this week on the Alliance's knowledge sharing platform, as well as YouTube channel. And just let me know if you need any assistance throughout. Send me a chat message here, and would be glad to help you. And I'd like to thank our speakers for sharing their time so generously with us. We have quite a nice panel today. So with that, I'd like to introduce our first presenter, and that's Ciara McCormack. And she is Assistant Professor of Exercise Science and Health at Maynooth University in Ireland. And she'll be presenting first today. Thanks very much, Ciara. Go ahead.
Great. So good morning, good afternoon, or whatever. I know we're all on different time zones. So thank you to the Alliance for Pulmonary Hypertension for having me here today to speak on this topic. So I won't dwell too much on different forms of I suppose remote digital telehealth that we have. But what I want to talk about over the next few minutes or so is specifically focusing on tele-rehabilitation. So in terms of, as we all know, we're all online today. So when we think about telehealth or tele-rehabilitation, we're thinking about taking that from the hospital to the home. It's often supported by digital technology. So I'm going to present why tele-rehabilitation is important in the area of pulmonary hypertension, and then talk you through some of the work we've done here in Ireland on remote-based exercise interventions for pulmonary hypertension patients and the findings from that research as well. So just I suppose, to set the scene, when we think about exercise rehabilitation, up until recently in pulmonary hypertension, it mainly was based in the hospital under supervision, or in community base. But in the last couple of years, we've had more research done in moving it from the hospital to the home, and that has been done in many different formats in terms of using just phone calls or app-based interventions, using the internet, video calling, number of different ways. And really, the benefit of moving it from hospital to home is that accessibility piece that I'll touch on in a moment. But before we get into the tele-rehabilitation, I wanted to just set the scene for those who may not be so familiar with the background of exercise in terms of pulmonary hypertension. So in the last couple of years, so since 2006 was when the first ever exercise study was conducted in pulmonary hypertension. And in 2019, the European Respiratory Society released a statement to say that exercise training was effective, safe, and cost efficient for those living with pulmonary hypertension who were stable and under supervision in exercise training. So this is a really important research that has really helped advance the field. However, the problem with, I suppose, exercise training in the hospital, as many of you will know, is that many of the centres, and I understand this diagram doesn't, or this map doesn't pinpoint every PH centre of excellence, but as you can see, most PH centres are located in one specific area in a European country. And for us in Ireland, we only have one centre based in our capital city in Dublin. And so my challenge was to develop an exercise programme that was suitable for our population of pulmonary hypertension patients living in Ireland and that was accessible. And really, what we found was some of the barriers for us to do it in the hospital for us was really that travel time that would be required, as many of our patients live very far away. The time that would take them to get to there, and also time within the hospital to identify space, the fatigue and the physical and the, I suppose, the mental side of having to travel to the centre, and then the geographic spread. And so what we looked at was this model of care that would bring remove from the hospital to the home. But first we wanted to understand, well, what did our patients want? And so we conducted some qualitative research, and what we found was that patients said there was a lack of physical activity knowledge provided to them. They actually wanted a home-based setting. So that was very interesting for us to find that the preference for them living in Ireland was home-based. They wanted accountability and monitoring while doing it, and they wanted clinician-delivered physical activity information and guidance in the sense that they wanted their clinicians to point them in the right direction and provide them information or support or services that they needed to be physically active. And so I developed the physical activity home base or pulmonary hypertension and home based exercise intervention, or FAB for short, that you'll hear me refer to it. And this was a remotely delivered exercise intervention that included virtually delivered induction sessions. So we had 3 education sessions. We had one-to-one health coaching sessions that took place on Zoom platform, like we're doing so now. We developed physical activity manuals and logbooks specifically for our pulmonary hypertension patients. We provided them with specific exercise videos, a stationary bike, and a Fitbit wearable tracker that some of you may be familiar with, already have a device yourself, and a chest worn strap so that we could remotely monitor their 6-minute walk test. And so our intervention included both males and females. Average age was 50, and we had patients that were living almost 200 kilometres away from the centre engaged in this programme. So really, we were able to reach people at the far end of our small country here in Ireland. And we also conducted the assessments remotely. And I know we'll hear later on today more about the remote assessment models, but we were able to remotely real-time monitor the 6-minute walk test, which allowed us to make sure the patient was safe, allowed them to capture the walk distance that they were doing, the step cadence, their heart rate, and their SpO2 oxygen saturation. We also conducted strength testing via Zoom. And then we posted out any additional questionnaires, which nowadays we probably would have done online or via app as things have changed. And the intervention was conducted at home in the patient's own home at a time that was suitable for them. So they were given a program that included a mixture of walking, cycling, resistance, upper body and lower body exercises, and some respiratory breathing exercises. And the patients would work through this on their program that was individualized to them based on their baseline measurements and how they were progressing over the course of the couple of weeks. And this will be decided on during their health coaching session, which took place on a bi-weekly basis via Zoom, as I mentioned earlier. What was important that patients worked progression was as tolerated. It was individually described, and it was progressed based on the frequency, intensity, and time and type of exercise they were doing. And really, we also were obviously measuring safety measures. They had pulse oximeter, and we're working off monitoring their Borg, which they logged in the logbook. And what we saw, I won't talk too much of these, but what we were really interested in this particular study was really looking at, was it safe and was it feasible to conduct this type of exercise intervention remotely, do the testing remotely, deliver the intervention remotely, and for patients to work on their own and report back with the monitoring. And then to see the impact it had on patients on a number of different markers like physical activity, quality of life, and psychological constructs. And we've published our research, but the main thing I think that's important here is that in this cohort, what we found that it was safe for exercise for patients to exercise at home. We had no adverse events. It is important, though, to note that obviously this was a research project, so there was an inclusion exclusion criteria, and patients, were screened prior to taking part in this, and that's an important part of when we think about remote delivery of tele-rehabilitation because it may not be for everyone. But what we found was that over the course of the 10 weeks, we've seen a significant increase in the quality of patients' report quality of life, their 6 minute walk test, their daily step count, their sleep duration, their confidence in their ability to exercise, and reduction in fatigue levels. And we found that it was both feasible, it was implemented as per plan despite challenges during the pandemic. Patients remained highly engaged and adhered throughout the program. They reported to be very enjoyable and acceptable, and they received to be very practical and usable, that they were able to exercise in the comfort of their own home. And I also like to always to think as what is the patient's feedback. And I won't read out this whole quote, but I think what's really important here is that this program gave this particular patient the opportunity to engage in an activity that they felt in control with and seen benefits despite living with pulmonary hypertension for many years. And one really stood out to me here is that they really wish that this was something that was provided for them earlier. And so what we've seen in the last number of years is that there's a real push towards patients wanting to be more in control of their life, engage in other activities such as exercise, physical activity, their day-to-day things that they like to do. And exercise can be a really important tool to help them do the things that they want to do. Importantly, we got some patient feedback from engaging in the FAB trial, and what they found was that it was convenient and accessible, that because they had to do the exercise themselves, they were using their watch to monitor the symptoms, write in their logbook, report back to the health coach. They were able to develop their development of exercise self-regulation skills, so they understood when they were pushing themselves too much or too little, and to understand their symptoms if they had any. They really valued the support and accountability that they got from the health coaching sessions. And they also talked about the physical and overall well-being improvements that they noticed over the 10 weeks. And really, what we're trying to see is that we now notice that exercise and tele-rehabilitation, like many things, is becoming very important for patients. But I do recognise that there are still unanswered questions when it comes to tele-rehabilitation in pulmonary hypertension as to what patients would benefit most, what's the optimal way to deliver it, and how can we increase the accessibility, particularly for those who may not have access to devices or phones. And so we still work in this space and we'll try push and continue to increase that accessibility. And just to finish off, where do I see the future going? I really think that wearable devices, and I'm sure we'll hear more today, are providing a really great opportunity for the clinicians and healthcare providers, but for the patients to help manage and improve their physical activity. Apps are on the rise, and particularly in pulmonary hypertension specific ones, and there's some work we're doing it. Our healthcare is getting more connected, and my hope is that there is an opportunity for all patients who are suitable and stable and medically clear to exercise at home, that they have the opportunity in the future to do so. Thank you very much.
Thank you very much, Ciara, for that excellent presentation. And next up, I want to welcome Steve. Steve Van Wormer is the president of PH Aware, and he's going to show us a very exciting app today called HeartWorks. Steve, please go ahead.
Thanks so much. I want to talk to you about a new pulmonary hypertension mobile research and resources app called HeartWorks. This is an app that is happy to say available in every app store that has a pulmonary hypertension advocacy group across the planet. So that's 40 plus app stores, 40 plus countries rather, in 25 plus languages. So let me tell you a little bit about PH Aware just very briefly, we're a nonprofit organization. I'm talking to you from Los Angeles. We're dedicated to raising global awareness and accelerating research for pulmonary hypertension through technology like mobile apps and storytelling that amplifies the voices of patients worldwide. So, what is the HeartWorks app? It's basically a mobile wearable health data collection system. It's got full data, privacy protection, HIPAA compliant servers, real world patient experience data. It's really was born out of the idea of doing out of clinic or in out of clinic hybrid research studies. Much like when a patient, pulmonary hypertension patient, goes to a clinic, they might do a 6 minute walk test once, two, three times a year, and that really kind of determines their course of treatment. And so our big idea is that a patient with a mobile phone does 100 6 minute walk tests a day every day. And so it was really about big data and getting more information to researchers and doctors for this disease. This app is not just for patients and caregivers, but it also has resources for HCPs, medical professionals, some CME. It really is meant to be used by the entire pulmonary hypertension community. As I mentioned, it's in basically every app store on the planet, and it is available in native languages for all those various locations. There's clinical trial matching tools and critical trials finders. There's global PH news feeds from across the planet from many great organizations. There's a podcast player, which we'll get into, and more importantly, a curated AI system, a patient experience portal, and we'll talk about that as well. But first, I got to say, we couldn't make this without a really core collaboration with many great organizations, many trusted organizations, I should say. Places like PHA Canada, Team Phenomenal Hope, Stanford Wall Center, who did 3,000 plus 6 minute walk tests to help validate this app, PHA Europe and Global, BioNews Services, which includes pulmonary hypertension news, pulmonary fibrosis news, Scleroderma, PPHnet, which is a pediatric conglomerate of 15, 16 hospitals across North America, PHA UK, AfPH, of course, TBX for Life, Vanderbilt, which is running a clinical trial, and the University of Alberta, who's also doing a study called CRAVE with us. So again, just some top line information about HeartWorks. I said it's a wearable device that works with your Apple iPhone, your Apple connected watches, Android devices, and Android smartwatches. You don't need to have a watch, but if you do have a phone, that's basically what you need to do these 6 minute walk tests. But what's really doing is simplifying and allowing clinical research participation remotely and to really help push the science forward. And as I said, it delivers personalized education for patients, caregivers, clinicians, advocates anywhere, anytime across the planet. And let's see what we got here. This is an example of it really was born out of the idea of a remote 6 minute walk test. These are just a few screenshots showing what you will see once you download the app, some pre-walk information, some pre-walk questions and answers, and then again, you have a 6 minute walk route. And that information is stored locally on your phone that, let's say you are not in a trial, you're just a user, a patient or non-patient user, that phone is stored on your device. And so you can see those trends in reports and then share that with your medical professional when you see them and say, hey, I'm walking further, I'm walking less, so you can determine that. I'd be remiss if I didn't mention our podcast series, which really has helped us amplify the patient voice over the last decade. All these podcasts are kept, 600 of them rather, come out weekly. And we've been recognized by two third-party individuals, organizations, as the #1 PH podcast on the planet based on our relevancy, social followers, and freshness. And it's really about delivering information to patients and community because there's a lot of people who live remotely that are isolated geographically, isolated mentally, isolated financially. Maybe they have insurance, they don't have insurance. So what we do is we're bringing the best minds on the planet in a weekly podcast series in our hope that no one gets lost and missed in the shuffle. So this is a really kind of the heart of the app as well, is every interview we've ever done, which is over 600, every video we've ever made, every webinar we've been poster session or white paper we've ever been involved in has been fed into an AI system, and it creates the ultimate patient lived experience portal. We do not believe that there is a larger library of patient experiences bigger than our podcast series. And so what you can do is actually about a couple weeks ago, we were at the ATS Respiratory Innovation Summit, and somebody was talking about, oh, we could make a chat bot for a website that can emulate a patient. This isn't emulating a patient. This is actually real world patient experience. And I'm proud to say we've asked many people to try to stump it, and that hasn't happened yet. And so basically, you can ask questions about pregnancy, about transitioning, about transplant, etc. And again, it's in native 20 plus languages. Uh, Daily news is brought to you from all across the planet. Trusted organizations like Pulmonary Hypertension News, PHA Canada News, PHA Europe, AfPH, PHA UK. So no matter where you are, you're getting news updated basically daily. This just shows you when you download the app kind of how the experience works. You're going to say, I'm a patient, I'm a healthcare professional, I'm a community supporter. You answer a few questions. It takes about 30 seconds to put this together. Male, female, when were you diagnosed? Which type of pH you have, and some basic demographic information. Same goes for if you're a healthcare professional, just so we know what specialists are using this thing. I'm a cardiologist, I'm a pulmonologist, I'm a nurse practitioner, I'm in academic practice or community practice. Here, I'm just showing you a few dashboard screenshots of some of the information I went over. Podcasts I mentioned, 6 minute walk test. You see there on the left, reports. That's where your 6 minute walk tests will land. There's you can find a PHC specialty centers. This is U.S. based. You can find every patient organization worldwide, email, URL. And in the resources tab here, you see there's another breakout of various other groups related, HHT, TBX for Life, clinicaltrials.gov. We have publications from all the world, PH symposiums, all the guidelines, and videos as well. This is just shows you a little bit more. The phone knows where you are once you registered. Oh, I'm from Colorado. Boom! It shows you the basic all the specialty centers that are in and around that state. Here's in the second screen here, you see the podcast. You can search there by anything you want to search by a speaker, by, like I say, transplant, CTEF, by pediatrics, and all the ones that are specific to that need basically show up. Here's just a screenshot showing you PHA Europe's news feed, and on the far right, as I mentioned, a clinical trials finder. You answer a couple basic questions, and you show a search radius, and it will actually, for all intents and purposes, pre-match you to clinical trials that you're likely to qualify for, as opposed to like just going to clinicaltrials.gov and trying to weed through hundreds or dozens of sites. So at the end, as I wind this up, I just want to say this app is more than just a digital health tool. It's a global call to actions for patients to really take control of their patient journey and share in their rare. With this platform, we're uniting patients and researchers, clinicians, in a shared mission to accelerate and improve outcomes for the pulmonary hypertension community. And it's really our hope that because based on a lot of conversations we've had over the years, is people get information from all over the place, and they have to go to this website and that website and here, there, and everywhere. And what we're really trying to do is go to the best organizations, pull in the best content, and make it a one-stop shop, because God forbid someone is diagnosed with this disease. Our hope is that when they walk out of that first clinic visit or that first referral, that by the time they're walking to their car, they can download this app and be listening to what, reading about this disease, hearing other people that share that experience, looking for doctors, finding a center, and really connecting with their disease. And I'm going to leave this last screen up here for a second. Again, if you want to learn more about it, it's at our website, phaware.global /HeartWorks app. But if you take 20 seconds and take a screenshot, the QR code on the left is for Apple app stores, and the one on the right is for the Google Play app stores. And it just takes, like I say, 30 seconds to register. And we really hope that the community can find this useful. I'll say in conclusion, I've mailed out about, oh, geez. Hold on, am I still on the screen share? I've mailed out about 2,000 of these flyers to various clinics and hospitals and doctors over the last week. So we're doing it one support group, one doctor, one hospital at a time. So thank you so much.
Awesome. Thanks so much, Steve. And yeah, I downloaded the app just as we were getting going today, and I'm excited to explore further in it based on what you told us today, and can yeah, also assure the audience that it is as easy to get started as Steve mentioned. So thanks so much for sharing that. Yeah, Paula is going to present next to us. Dr. Paula Appenzeller is a clinical research fellow at the Royal Papworth Hospital NHS Foundation Trust and the Victor Philip Dalladé Heart and Lung Research Institute in Cambridge. Paula will speak about remote monitoring technologies, and your slides look perfect. Please go ahead.
Thank you very much for the introduction, and also thank you very much for inviting me to talk, and for the previous speakers about really sharing their exciting and new technologies. So my talk is a little bit more about an aerial view of why we as clinicians and researchers think that remote monitoring technologies are important, and what possibilities we currently have as a PH community. So first question is, and we still already answered that, but the first question is, what is remote monitoring? So we understand as remote monitoring that we are using digital devices to manage and monitor disease outside of the hospital and in a patient's home and environment. So we are trying to see if a disease improves or gets worse. And we can use this by using a smartphone, as we just seen in the previous talk, or by smartwatches, also as we have seen in the first talk. But also we can use some more specific medical devices, such as implanted heart rate monitors, that then collect the data. The data is then shared remotely with the clinical care teams, and they can take decisions, for example, increasing or decreasing diuretic medications, or upping the dose of pH medication remotely, so that the patients don't actually have to come into clinic. So the data we collect could be step counts, heart rate, daily weight, specific tasks, or even questionnaires. And we can really use this data to monitor the disease the same that we would do in a hospital, just in a remote setting. We might ask ourselves, why do we think this matters? Why is it important? And in the recent years, and especially since the pandemic, there has been an increasing pressure from regulators and from the public to move traditional care from hospital into the patient's environment and to use digital devices. And I'm going to give you an example that is a little bit off topic, but it's a perfect example of how digital devices can improve disease management. So the example is diabetes, and for people living with diabetes, it's really important to measure blood sugar levels several times a day, and then to titrate and adjust the dose of insulin they measure accordingly. And traditionally, people have done this by using fingerstick measurements, so they're taking their bloods, measuring blood glucose levels, and then adjust the insulin dose. But now we can do this a little bit more elegantly. So if we imagine this shaded area on the graph to be the optimal range for blood sugar, single time point measurements before each meal might look something like this. And we can see at first sight, this all looks really well, everything is in order. But what we don't see is that the blood sugar levels are actually much more varied. And there are some unnoticed highs and unnoticed lows that go missing if we only look at single time point measurements. And in 1999, the FDA approved a continuous blood sugar measurement device that is a sensor on the arm of the patient and will measure the blood sugar each minute. And today, many patients have automated insulin delivery systems that rely on these continuous measurements. And this is a perfect example to show you how, if we just measure something in single time points, we might miss something, and it's not really representative of the whole course of a disease. And we can take these examples to many more areas. We could, for example, take normal arterial hypertension, where we have known that white coat hypertension is a real problem, and patients generally have higher blood pressure if we measure them in clinic or in the GP practice compared to when we measure them at home. And that's also why, for example, in hypertension, we have introduced a 24-hour blood pressure measurement at home before we could properly diagnose hypertension. And using digital devices is just an extension of this concept. So we are using something to monitor the disease in a higher granularity, and it'll have a little bit more complexity, but it will give us a better understanding. And essentially what we want to achieve by it is we want to improve disease management. So digital devices can give us objective data to complement what a patient tells us in clinic, or what a patient feels, or what the symptoms actually mean. And it allows us to have a continuous monitoring between inpatient visits, and they also monitor the patients and the people living with the disease at home in an environment that they are familiar with, and in an environment that matters much more than in clinic environments. So we can see how the disease affects people in their everyday life and not just when they're in hospital. And then, of course, using AI and machine learning that is now becoming more and more popular, we can use all the data we collect and use something called pattern recognitions to detect improvements or deteriorations early, and then also adjust treatment in a more personalized way. And last but not least, it's also, now that we have the opportunity to collect data in a much more granular way, we will gain a better understanding of how the disease naturally improves or deteriorates, and how people with the disease live in their daily lives. So this is more general, but how can we actually use it in PH? And in 2024, the PVRI, the Pulmonary Vascular Research Institute, has conducted a global patient survey. Some of you might have participated in it. And we have seen that 93% of patients with PH have a smartphone, it's a phone with internet access, and 50% of these already use it to monitor their health in some way. And the easiest way to approach digital monitoring solutions is to take something that we are very familiar with and translate it into the digital space. So the survey also asked if patients would feel able to complete a digital 6-minute walk test outside of the hospital using a smartphone or an app. And again, we could see globally the answers were really high at 80%. And also we could see that it didn't really vary across the different regions of the world. And together, this data is very encouraging. It shows that remote monitoring is definitely feasible, and it shows that patients and people are willing to engage with it. And it also shows, and we have seen this before, that the 6-minute walk test is an easy first step. So we have heard a lot about the 6-minute walk test in the previous 2 talks, but this is a concept that is the most developed in PH. So over the last decade, if we go back to the literature, the PH community has developed several different versions of a digital 6-minute walk test. That means patients can perform the test that they usually would perform in a hospital corridor supervised by nurses or researchers. They can now perform them at home, in their gardens, in their houses, or in their environments just outside their houses using a smartphone app or a smartwatch. The distance walked is measured through step counting algorithms or GPS signals, and it's stored on an app platform and where it can be shared with clinicians. And the table on your right gives you an overview of how many groups over the last 10 years have developed some version of the digital 6-minute walk test. And there's lots of different methodologies behind it. Some are indoors, some are outdoors, some use GPS, some steps. But overall, we can say as a community, we're quite confident to say that the digital 6-minute walk test is something that is safe and is feasible, and patients really like it. And it's also quite accurate. So you can see that on the graph in the middle, which is a correlation graph. You can see that the standard 6-minute walk test measured in hospital on the horizontal axis versus the digital 6-minute walk distance on the vertical axis, you can see that the points are really close together, meaning that they're very closely related. Meaning that we are quite confident in saying that what we measure with the phones or the smartwatches is what we would measure in clinic when we just counted the laps someone walks. So we can definitely use a 6-minute walk test as a monitoring device outside of the hospital. And the community has even gone further and is now exploring different versions of the 6-minute walk test. some of them are shorter. So we have a digital 1-minute walk test and a digital 3-minute walk test that are currently explored. And this is based on feedback we got back from patients saying that they would prefer a shorter walk over 6 minutes. And we have looked into this and we've seen that shorter walks actually carry the same clinical information as a normal 6-minute walk test, but they obviously have the advantage of being more convenient to perform in a home environment. And again, we have the correlation plot on the right where we can see in the different colors a 1, 2, 3, or 4-minute walk test and how it relates to the normal 6-minute walk distance. And we can see that they are very closely associated. And another concept that is also currently explored by a group in America is to measure something called cardiac effort. And this is used by, we're measuring the continuous heart rate during the 6-minute walk test, and we divide the total amount of heartbeat divided by the distance the patient has been walking. And it gives us an idea of how intense the 6-minute walk test was. So we have seen that this adds meaningful information to the 6-minute walk test, and it makes it a little bit more interpretable and also comparable if we want to measure it longitudinally over several weeks in a row. And the group that's doing this is doing it with this little patch. You can see on the picture, it's called a biostamp, and you can see that this little patch is measuring steps and heart rate. And it is an example of how advanced we can be in our digital monitoring. It really doesn't take a lot to do so. Another really exciting thing that we are doing is we are using implantable devices called cardiomems that are paperclip-sized devices that are directly implanted into the pulmonary arteries at the diagnostic right heart catheter. And they give you, they continuously measure the blood pressure in the lung veins, in the lung arteries, and the resistance. And the group in Sheffield who is pioneering this has been able to show that it has, we can directly see the impact of therapy by using these devices. So on the graph, you can see in red the total systemic resistance and in blue the total pulmonary resistance, which is normally elevated in pH, and which is also the reason why the symptoms are, like the higher it is, the higher are the symptoms in general. And you can see that the curve dramatically drops down after therapy was initiated, and it stays low while therapy is administered, and it will rise again after the therapy was, after the drug was withdrawn. So we can use these devices to see the direct impact of drugs on the pulmonary hemodynamics, which is what we define the disease by. And we can also use them to find the perfect dosing and to be a bit more personalized in our treatment. And there are many more different examples I don't have time for, but to conclude, so the term remote digital monitoring covers a wide range of solutions, and some of which are as easy to just carry a smartphone or to apply a patch. And the PH community is currently exploring very different solutions. Most of them are sort of slowly making their way into clinical trials, although the clinical implementation to be actually used in a regular service is still a little while off. And the overarching goal we have to remember is to use digital monitoring to improve disease management and to empower patients to monitor their disease in their own houses. And lastly, it's very important that any potential solution going forward is developed in collaboration with people living with the disease and clinical teams together to create something that is both informative and acceptable for everyone involved. And with this, I thank our patients for participating in our trials. Thank you very much.
Thank you, Paula. Very interesting to see what kind of the cutting edge of remote monitoring is right now at the moment. With that, I want to invite next and last but not least, Gregg Rawlings, who's a lecturer in clinical psychology at the University of Sheffield in the UK. Greg, please go ahead whenever you're ready.
Hi, everyone. Thank you very much for having me. My name is Gregg Rawlings. The title of my presentation is Online Mental Health Resources and Peer Support. So just to introduce myself in case you don't know me, so my name's Greg. I have degrees in psychology from in the UK. I have a PhD in neuroscience. I am a qualified clinical psychologist. I work 2 days in the NHS working with adults with a learning disability and 3 days as a lecturer in clinical psychology at the University of Sheffield. And that's where I do my research in regards to PHA. PHRI. So I work with colleagues at Sheffield Teaching Hospital, which is a PH specialist centre, as well as PH in the UK. So this is my second time presenting at the webinar, so thank you for having me again. So I presented a couple of years ago where I discussed our work looking to develop a self-help guide, remote guide for anxiety and pulmonary hypertension. This is a self-help guide that can be completed in the comfort of your own home. It's based on a type of treatment called CBT, or cognitive behavioral therapy for short, and as I say, it helps people with PH manage anxiety. So if you're interested in hearing more about the program, there's a YouTube link underneath, and then if you're interested in the program, there's the link above. And I suppose the reason for that work, or one of the things that helped reinforce the need for it, is this review that was published a few years ago, looking at rates of anxiety and depression in pulmonary hypertension across North America, Europe, and Asia. And it involved over 2,000 patients. And what they found was that rates of anxiety and depression were much higher than what we'd expect to see in the general population. So it was around 37% for anxiety and around 28% for depression. So for comparison, we'd expect to see around rates of 5 to 6% within the general population. So much higher in people with hypertension. This graph in the review is particularly important, at least in my view it is. So this is looking at predictors of anxiety and depression in hypertension. And I just wanted to draw your attention to the information in this red box. So this is looking at severity of PH symptoms as indicated by the Q functional class. So this is the idea where functional class 3 and 4 is more severe in terms of symptoms compared to 1 and 2. And what you'd expect to see is that WHO functional class, so severity of PH symptoms, is significant predictor of depression and anxiety, when actually that's not what we found. So for it to be significant, these values here would have to be less than 0.05. So this would suggest that treatments that aim to address the severity of pulmonary hypertension as measured by WHO functional class system maybe not the most helpful. There's something else going on here that might account for why rates of anxiety and depression are so high. The way that we can measure symptoms of depression is using screening tools, and these are self-reported, so they can be completed anywhere, so in clinics or via apps or online. And this is one of the most common methods of screening for depression. So this is 9 items that someone would respond to over the past 2 weeks, looking to see how often they experience some of these symptoms related to depression. And then the score can help us to understand whether they're likely to experience depression or not on the clinical level. It is only a screening tool, it's not a diagnostic tool. However, it is a relatively easy measure to administer and complete. Some of you may be aware, someone's already mentioned the global PH survey that was published this year. So this was a survey involving over 3,000 patients from 88 countries. And then on the right-hand side, you can see the percentage of people who experience or who endorse some of these experiences. So 27.5% of people reported low self-esteem, 26.5% reported anxiety, so fear, and so on. And this led the authors of that paper, of the survey, to conclude that psychological support is a highly requested but frequently unmet need, reinforcing the importance of holistic care models in multi. So recognizing that rates of anxiety and depression are high in this population, recognizing that there's multiple barriers to accessing support, that we've already developed a resource to help with anxiety. So what we've done recently is develop a resource that people can complete at home with self-help based on CBT targeting depression in pulmonary hypertension. And these papers, this paper is now published, and the resource is available. I'll share the link later on. And what this resource is looking at is it's 4 booklets over 4 weeks, and each booklet corresponds to different topics. So the first one, for example, is looking at depression and pulmonary hypertension. So this is helping people to understand symptoms of depression and how it might interact with PH. Moving on to week 2, booklet 2, which is looking to replace inactivity. So this is a key aspect of CBT for depression. It's known as behavior activation. So it's around helping people to change behaviors in the hope that it will help improve mood. And then what we might find is that feeds into more positive cycles. So what we've done is we've tested this intervention So as I say, it was self-help, so people could complete it at home. We had 68 people take part, and we randomized people to one of two conditions: one where they received the intervention, shown by this blue line, and one where they're in the control group. This is where people were allocated to a waitlist condition, so they didn't receive anything. We assessed depression before the intervention, after the intervention, so only 4 weeks later, and at 1 month follow-up. And we asked people to complete PHQ-9, which I showed earlier. This is what we found. So both groups scored moderate depression, and using the PHQ-9, we can look at the clinical cutoff. So this means that anyone scoring above this cutoff may benefit from speaking to a healthcare professional and receiving additional support. What we found after the intervention was those in the CBT group reported a reduction in their difficulties related to depression, and then at 1 month follow-up, that was maintained. We also asked people who took part to complete the Emphasis 10, which is a health-related quality of life measure. It's 10 items asking around difficulties related to PH, or particularly around breathlessness, for example, or fatigue, or some of that other psychosocial impacts. So PH does not control my life, I'm independent, I never feel like a burden. Those were some of the questions that people answered. And again, we asked them to complete the baseline, post-intervention, and follow-up. And as you can see here, those in the CBT group, interestingly, didn't score much difference in terms of baseline and post-intervention. However, at 1 month follow-up, they scored an improvement, and this was statistical improvement. We obviously have to bear in mind that it is a relatively small sample size, so more research is needed, but nevertheless, the evidence is promising. So, as I say, our intervention shows promising research that can help with depression symptoms, but also help with quality of life. We also asked people what they thought about the intervention, and the majority valued that it was specific to pulmonary hypertension. The majority reported feeling more in control of the depression. As I say, relatively small numbers, so 15 people responded, but nevertheless, still promising data. People with pulmonary hypertension thought that other people with PH should have access to the intervention. A similar amount said that it helped them a lot, and they'd recommend it to others. And there's some quotes there. So people talking about how the self-help intervention give useful strategies to help maintain my mental health and make sure I'm doing what I need to support my physical and mental health. So as I say, just like the anxiety intervention, the depression intervention is now widely available via PHA UK. And as I say, you don't need to access this through your PH provider or PH service. This can be accessed remotely. And this also contributes to the other forms of remote support that PHA UK offer, so namely the listening line. So this is a telephone line where patients with pulmonary hypertension can ring and receive support from someone with knowledge of pulmonary hypertension. It's not counselling or therapy, but it's someone with expertise in pulmonary hypertension. In addition to PH Connect, so this is an online platform where people impacted by PH can access and find other people who have shared experiences, so whether it's to do with medication or type of PH or gender or age or ethnicity, and reach out, and that's where you can have that connect and that peer support. So as I say, we've developed a resource for anxiety, resource for depression, and they're both remote and can be accessed by self-help. What we're currently developing at the moment, and the interventions developed, we're just in the process of making it available, is we are looking to test an intervention that we've developed looking at sleep in hypertension. And this comes on the back of our research, but also some other research looking at the high rates of sleep difficulties in PH. So, for example, recently we interviewed 111 adults with hypertension. We asked them to complete validated measures of sleep. 80% were classified as having poor sleep quality, and around a third reported difficulties with daytime sleepiness, and around a third report clinical levels of insomnia. So our intervention looking at sleep will be available again with the aim of being remote and self-help. Thank you very much for your time. Thank you for having me again. I'd like to thank everyone who's took part in our research, in addition to PHA UK and collaborators. Thank you.
Thank you, Greg. Really appreciate it. And yeah, if the other speakers want to come back, we have a few questions, if you don't mind answering them. And I think the first one was for Kyra. How did patients do after the program? Because she hears that it's hard to keep doing the exercises without a little nudge after rehab.
Yeah, so that's a really good question. And as probably many of us that have experienced, sometimes when you're not being followed, it's easier to not do something than to keep it going. So one thing that we did find, we have done follow up, we have some follow up data to be published on this, but many patients did actually continue to be physically active, but maybe not as highly active as they were during the intervention. What they found useful was that they still had access to the resources and the tools that they've developed during the intervention, such as how to monitor and self-manage, was really useful to tools for them to keep doing when they didn't have the health coach and support. However, a lot of them mentioned that it would be useful to have it, or have ongoing check-ins, and I suppose, like Greg, it for research science, we are trying to explore the best options and what's the most impactful and best way to continue to support or to taper support after being involved in an intervention that is quite monitored quite intensively. So it's very much dependent on the patient and the individual. I suppose the goal with any intervention is to try as much as possible to help the individual to become self-motivated to self-manage as well. But I do think there's a real important role that the clinicians play in, particularly when it comes to exercise and physical activity, in ensuring that they are at least asking patients how they are getting on, if they are being physically active, and if they need more support. And so, yeah, it's a million dollar question as to how do we keep patients engaged, and how do we support or offer more support for people who may need it, because everyone's very different, and it can be very at different time points as well, depend on maybe where they're at with their pulmonary hypertension.
Thanks, Ciara. Steve, I see you had a few questions in the chat that you kind of already responded to. Is there anything,
Yeah, I mean,
generally
I can
that
make
you
it.
want to
Yeah, I can
say?
articulate it a little better. Someone asked if how do we keep the data relevant? On our, not just in our app, but on our website, on our homepage, and there's a vendor. It's called Match. It's a matching tool. So basically, if anybody's ever went to the US clinicaltrials.gov, it's just a web of all kinds of stuff, and there's dozens or hundreds of various studies going on, the dates and how you qualify, how you inclusion, exclusion. So what our Match tool does, basically, if you, it's kind of preset for pulmonary hypertension, but you could set it for anything, or CTEPH or whatnot. And you answer 4 or 5 basic questions. You put a search radius, and based on your questions, it basically pre-matches you to ones that you're really going to be qualified for potentially, as opposed to just randomly picking 20 trials. But as far as the dates and relevant information, it's tied directly to clinicaltrials.gov. So if something goes offline or it's filled or whatever, it's going to go away. But this platform just makes it a little cleaner and easier to navigate. Another question that was there in the chat that I answered up, but I'll state again, was does our app, our HeartWorks app, connect to other phone apps? In the case of iPhone, which I'm an Apple user, yes, it right when you log in, it will ask you like your height, your weight, and some people have asked me like, why are you asking for my height and weight? It's like that's if you are going to want to connect to do the 6-minute walk test or connect to your Apple Health app. So that it works in concert with that, and whatever the relevant version for Android devices are. I don't know what it's called in Android. I'm sorry, I don't have an Android device. Was there any? I think that was the 2 questions that were for me, unless there was
Yeah, I
something.
think so. Thanks for adding that other color to it, Steve. Yeah, those details are appreciated. Paula, the next couple questions are for you. Suzanne was wondering, do you find that people can be more honest about their symptoms, etc., using a third person tool?
This is a really good question, and it might need to be forwarded to Greg as well. We have done some work on questionnaires, and what we see is that we can see a little bit more change when we use like questionnaires more regularly, and people actually have to fill them out, not only once every 6 months or once a year, but every 2 weeks. In terms of what the watches are measuring, we don't really ask for symptoms, but we can definitely see what people are doing. So in that sense, if you decrease your activity or increase your activity, the watch is just measuring what you're doing. So you can't sort of lie, or you can. So that might be a way to be more honest. But with the questionnaires, maybe Greg has an answer, or maybe you have done some work on this to see if people have some more information if they're using a tool rather than the person. Yes. Should I?
Greg,
Go on.
anything to add?
I haven't done the research myself, but obviously it's bearing in mind if you do create, if it is a peer-based outcome measure to begin with, the questionnaire or way of collecting data, and you develop a new way of administering that, collecting data, it's obviously important to make sure that's still validated and you're still collecting the same data. So yeah, that's just something to add.
Thanks. Paula, are you able to compare the results of the 6-minute walk test in hospital versus remote ones? That seems to be the biggest hurdle to compare them.
Yes, that's a spot on. Yes, so we are able to compare them in terms of if we do them in a study and we measure what we measure on the ground and we measure what the watches measure or the phone measures, they are really highly correlated. So they're really basically the same thing. And it gets a bit more difficult when patients take the tool home and then start doing their tests at home. And what we can see is that the difference or the distance walked varies much more than what we would expect on a week-by-week basis. So we are currently, most of the studies that have been done have just been showing in a single time point when we measure it remotely and we measure it on the ground like normally, then they are really highly correlated. And there's not that much data yet on how to continuously measure them over months at home. So, but data is coming in and we can see like we are collecting more digital devices and we are finding solutions on how to sort of overcome this problem. It's not a big difference. We can still deal with it. So I still think this is a really good tool to do. But yes, it is a bit of a hurdle to compare them directly. And
Thanks.
I see the next one.
Yeah, please go ahead.
Yes, so the next one
procedure.
Is how to insert a cardiomem. So this is the small device that sits in the pulmonary arteries, and this is inserted during a right heart catheter examination. So normally when you have the normal diagnostic catheter, you can insert this tool. It has two little clips on the side that will anchor itself into the pulmonary artery walls, and it swims in the middle. So it's not a big procedure, and it's been proven to be really safe. It's been mainly used in left heart failure, and it has been used for a couple of years there and really well explored. Yeah, great. Sheffield is doing a lot of these, so if someone's interested.
Great. The next question is for Greg. Is there a difference in people who get treated with IV treatment versus oral therapy? Because they always live with the knowledge that when the infusion stops, they have minutes, not hours.
I'm not sure if I understand the question fully, but I suppose in terms of my research, we don't differentiate in terms of who is eligible for our interventions. So it's all forms of PH, regardless of type or functional class or medication. So our inclusion criteria is very kind of open. There are some limitations. So for example, we won't accept people who have got thoughts of suicide or self-harm, recognizing that realistically self-help might not be appropriate. So we signpost them to the clinicians to have those conversations.
Thanks, Greg. Another question for you. Can the program be ordered from outside the UK as well?
I believe so. If you reach out to PHA UK, you'll be able to have those conversations with them and see whether it's something they could post out or make available via PDF, for example.
Great. And thank you to Steve for answering Joan. That will make this entire webinar as well as the 4 presentations that were given today available on the knowledge sharing platform and on the Alliance for PH YouTube channel after this. I just think it was an incredible discussion today, looking at technology, AI, what the future holds, and the fact that maybe a lot of these tools can help people better manage their pulmonary hypertension. Yeah, with that, I want to thank you all for attending. We really appreciate your questions and your participation, and also thank you to our speakers. We couldn't do this without you sharing your knowledge, and Greg coming back even a second time. Hope to have some of you back other times as well. Thank you so much for your time.
Thanks, and thanks, Basana, for having us as
Thanks,
well. Thank you.
Yeah,
thanks very
thanks,
much.
Pisana.
Thank you.
Thank you.